Welcome! You are watching Medicine with Dr. Moran. I'm Dr. Keith Moran. My video today is about colonoscopy. You hear about this often on TV shows or ad campaigns. Many patients are curious about the procedure. This is everything you wanted to know about colonoscopy, but were afraid to ask. What is a colonoscopy? This is the best test to view the colon for colon cancer and other abnormalities. Biopsies can be taken and are painless. Also, we can see polyps when we're inside the colon. These are small growths on the wall of the colon which can be removed. Polyp removal, known as polypectomy, is painless. The colonoscope is a flexible tube with a light and camera at its end. It has suction, water, irrigation, and an instrument channel. The colon is 3 feet in length or 80 centimeters in metric terms. The colon is often called the large intestine. Those two words mean the same. What does the colonoscope look like? This image labels all the working parts. Looking at the image, you will see that there is a button for suction to suction any liquid that might be present in the colon. There's also a valve so that we can instill air or CO2 to blow up or distend the colon. I use CO2, which gets absorbed quickly after the procedure, which significantly reduces distension and discomfort post-procedure. We can also utilize water to wash the end of the scope or the camera lenses, just like you would do with your car's window screen. Also, there is an instrument port where we can put down a variety of instruments down through the scope. The instrument connects to a Colonoscope Tower, as you can see in this image. Additional monitors in the room allow the nurses who are going in the room to see what's going on from different vantage points. The colonoscope has rotary knobs to control the tip of the scope. These are the two knobs here. One is a left and right, and the other is an up and down. The larger of the two is the up and down, and the smaller of the two is the left and right. This allows us to control the tip of the scope. In addition, the doctor holds the scope with their left hand and uses the thumb to control these dials, with the right hand holding the shaft of the scope. The shaft can be turned, which is what we call torquing the scope. This will adjust the view. It's just like rotating your camera from a landscape view to a portrait view when you turn the shaft of the scope. In the close-up pictures, you can see the air and water as well as suction buttons on top. There are also some additional rubberized buttons on the top which can be configured to record images. Other buttons can change the light that we're using from a white light to a blue light, which allows us to look at the lining of the colon and better assess certain lesions. One of these buttons can be configured to trigger a timer so that one can see on the screen how long it takes to withdraw the scope while looking at all of the sections of the colon. We inspect the colon on withdrawal of the scope. Studies have shown that doctors who have withdrawal times of more than 6 minutes find more polyps and more abnormalities than doctors who spend less than 6 minutes. This is one of our quality indicators of colonoscopy. Remember, you want the physician who's doing your test to spend time looking closely on the way out. This is an image of the colonoscope tip. This gives you a good idea of what the end of the colonoscope looks like. You can see the air-water channel is right beside the camera so that when we press the button, water will leak onto the video camera lens and clean it. There is a light source that allows us to see in this dark tunnel we call the colon. There is an instrument channel which allows us to pass a variety of instruments. Here in the picture you can see a biopsy instrument with a needle in the middle coming out of the biopsy port. The needle in this instance is to stabilize the lining of the colon so that the 2 cups of the biopsy instrument can then be closed to get a good sample. There have been many instruments that have been developed so that we can pass them through the scope into the colon to carry out different kinds of therapeutic interventions. All of the instruments that we use at my hospital are disposable. We do not reuse any endoscopic instruments. The only thing that's reused is the colonoscope itself, which is cleaned with high-level disinfectant after every case. Colonoscopic retrieval instruments. These are two examples of instruments we use to retrieve things within the colon. We frequently retrieve polyps as well as foreign bodies. On the left, there is a picture of a wide open net, which is simply placed over the polyp, and when you close the handle, the net will close. On the right, there is a 3-prong grasper, which is photographed wide open, but the 3 prongs will close, grasping the foreign body or other thing that you're trying to grasp, such as a polyp. These instruments, once they have grasped the lesion in question, can then be withdrawn. Colonoscopic biopsy instruments. These are some examples for you of the different kinds of biopsy forceps that we can utilize. They come in different sizes and shapes depending upon what you need to do. The image on the right shows the handle at the end of the instrument, which when pinched by the assistant fingers closes the biopsy forceps. The doctor will then pull the instrument out through the instrument channel, which takes a small bite of tissue from the colon wall. All specimens then are sent to the pathology department so that our pathology colleagues can look at the specimen both with their eyes at a macroscopic level as well as through the microscope at a microscopic level. A report is then made and sent to me, which I will then discuss with my patients. Polypectomy instruments. When we encounter a polyp, which is a small growth on the colon, there are different ways to remove them. Some polyps can be so large with areas of cancer within that necessitate removal with an operation as opposed to removing it incompletely via a colonoscopy. Generally, large polyps require an injection of saline and a dye, which helps us see the outline of the polyp tissue against the normal lining mucosa of the colon. The assisting nurse will pass me an injector needle with a syringe filled with the dye, as you can see in this image. I will place the needle into the colon wall beneath the polyp, and we will then inject. This will raise the polyp up from the colon wall. It gives us a cushion between the polyp and the colon wall. The colon wall is very thin, and the cushion is helpful for removal. After the injection, we select a polypectomy snare. There's a variety of snares on the screen now. These go through the colonoscope, and the loop will then go around the polyp. The loop we then tighten, and we use electrical cautery to cut the polyp away from the colon wall if it's a large polyp. Sometimes we don't use any cautery, and we remove it in a fashion that we call cold removal. After the polyp has been sectioned, we then retrieve it. Smaller ones can be sucked up through the suction channel, but larger polyps require a net for retrieval. Polyps of concern that may harbor malignancy can then be tattooed. We use a special tattooing agent. This is an example of one such product, which is called Spot. The syringe of Spot is attached to the injector needle, and we inject a small amount of this near the polyp site so that we can easily find the site again during follow-up colonoscopies. You have to remember that the inside of the colon looks the same throughout, except at the very beginning and at the very end. This really is the tattoo that you'll never regret. When we tattoo sites in the colon, we ensure that we will be able to easily find and reassess the site several months down the road. Often we need to recheck the site to see if there have been complete removal. We obviously don't want a small amount of residual polyp to grow and turn into cancer down the road. When we see colon cancer or large polyps that we cannot remove with the colonoscope, tattooing the site of the polyp is helpful for the operating surgeon at the time of an operation. The tattoo is easily seen from within the abdomen, and it shortens surgical times as well as improving safety. There are many other instruments that we can use. These two are some of the most common types. We use clips, as pictured here, to grasp blood vessels in patients who present with gastrointestinal bleeding. Clips can also be used to approximate tissue after a large polypectomy where there's a significant defect in the colon wall where the polyp was. Clips typically fall off days to weeks post-procedure. On the right is an example of a probe that we can pass down through the scope. There are different probes. Some can carry heat to cauterize a bleeding lesion, and other probes can carry a special gas called argon. The argon gas can be sprayed through the instrument all the way down to the tip to superficially coagulate tissue. This is an image of the colon. The colonoscope is passed firstly up through the anal canal into the rectum, and then there's a number of twists as it comes through the sigmoid colon and right up to the top here where the spleen is. We turn, come across what we call the transverse colon, and then all the way down the ascending colon to the very end, which is called the cecum, where the small little worm-like structure is, which is the appendix. There's a valve here at the end of the large intestine or colon, which goes up into the small intestine. That's called the ileocecal valve. There are many things that we can see at the time of colonoscopy. This slide highlights some of the abnormal findings. Many patients over the age of 70 have diverticuli, and we call this diverticulosis. These are areas of outpouching of the colonic wall, which look like little sacs, as you can see in the image here at the bottom. I'm pointing to two small diverticuli. This image shows small diverticuli, but they can be quite large, almost the size of the actual lumen of the colon. And they can make it difficult, if they're large enough, for us to know which direction to advance the scope in order to get around the colon. Diverticuli are weakened areas of the bowel wall which bulge outwards. The diverticuli are very thin-walled and they're easily ruptured. In patients with diverticulosis, about 5 to 15% of people will go on to develop an attack of an infection of one of these called diverticulitis in their lifetime. Other findings in this image include polyps as well as colon cancer, as well as inflammation within the colon. We can see this in two inflammatory bowel conditions called Crohn's and ulcerative colitis. Also, the appendix, which is the worm-shaped protrusion that I mentioned, can be seen in the lower left section of the image, and that can obviously get infected, and we call that appendicitis. Why do we do colonoscopy? In other words, what are the indications for this procedure? Screening colonoscopy is done in patients to look for precancerous polyps and colon cancer in average risk people over the age of 50. It is also done in patients with risk factors starting at earlier ages. Surveillance colonoscopy is done in patients who have had precancerous polyps or colon cancer to surveil their colon for the development of new lesions. Patients with inflammatory bowel disease, either ulcerative colitis or Crohn's colitis, require intermittent surveillance of their colon to assess for precancerous or cancerous areas. We want to visualize the colon when patients have lower intestinal bleeding. This could present with bright red blood in your bowel movements or in the toilet, sometimes even darker burgundy colored blood, or even black bowel movements which look like tar, and we call this melena. Sometimes we may suspect disease at the end of the small intestine. The end of the small intestine is called the terminal ileum. We can assess this by passing the colonoscope up through the colon, through the ileocecal valve, as I mentioned, into the small intestine, and the end of it is called the terminal ileum. Certain patients can have disease in this segment, such as carcinoid disease or Crohn's disease. Colonoscopy is always done when we suspect that patient symptoms could represent disease in the colon. Symptoms that might indicate the need for colonoscopy include chronic diarrhea, a change in bowel habits, constipation with weight loss, iron deficiency anemia, and abdominal pain. There are many other indications. Those are the primary ones. Colonoscopy is often done when there are abnormalities in the colon noted on other imaging studies such as ultrasound, CT, MRI, or even a barium enema. Patients may have presentations that require colonoscopy to be performed for therapeutic reasons, such as decompressing a colon that's quite dilated, or reducing or decompressing a volvulus, which is when the colon will twist on itself, causing an obstruction. Foreign body removal can be carried out, as well as balloon dilatation or stenting of narrowed areas. This is the laugh of the day. It's from Carla Burnett. The preparation is always the worst part of the procedure for patients. Going on clear fluids the day before and the laxatives that will trigger the bowel cleansing diarrhea can cause a lot of apprehension for patients. It's worth this minor hassle to have a good look at the colon to assess for abnormalities which might include polyps, both benign and precancerous, as well as to search for colon cancer. The preparation is a very important part of the procedure to ensure that the bowel is completely clear of feculent matter and that all the walls of the colon can be well seen. How effective the prep is a critical factor for colonoscopy. It is very important to read the prep sheet in detail at least 1 week pre-procedure. There may be medications that need to be held, and it's important to avoid nuts, seeds, popcorns, as I will describe pre-procedure. You will need to purchase the medication for preparation. An inadequate bowel preparation has a number of consequences. It takes the colonoscopist longer to pass the scope from the rectum to the end of the colon where the cecum is. It also takes longer to withdraw the scope, as areas which may be partially soiled need to be washed and then suctioned. It's obviously harder to find polyps when the colon is not clean. As I always tell my patients, it's much easier to find something in a room that's tidy rather than looking for something in a room that's messy. A suboptimal bowel preparation sometimes means that the interval between colonoscopy needs to be shortened, or if the preparation is truly suboptimal, the procedure simply needs to be repeated at the next available time slot. In other words, you might need to have another colonoscopy if the prep was not great. Suboptimal bowel preparations lead to lower likelihood of the scope being advanced all the way to the cecum. They also lead to a lower polyp detection rate. There is much higher risk of adverse events when the bowel is not optimally prepared, as it can be difficult to see which way the lumen is going on insertion. As I mentioned before, sometimes large diverticuli, which are thin-walled, can be difficult to differentiate between the colonic lumen in a suboptimal preparation. Pushing the colonoscope into a diverticulum could cause a perforation. Medications prior to colonoscopy. It is important that your medications are reviewed prior to the colonoscopy. Some medications, such as iron, need to be held beforehand. Typically, iron is held for 5 days pre-procedure. Certain blood thinners, such as anticoagulants or antiplatelet medications, may or may not need to be held. This is done on an individualized basis. If an anticoagulant is discontinued, there obviously would be a risk of a blood clot developing around the time of the colonoscopy, but this always has to be balanced by the risk of bleeding from the procedure. Aspirin and non-steroidal anti-inflammatory drugs like ibuprofen or naproxen may be continued safely in patients having a colonoscopy. Diabetic patients on medications will need adjustments. Typically for diabetics in general, the medications are reduced by 50% with close blood glucose monitoring during the preparation day and day of the colonoscopy. Even with a significant reduction in diabetic medications, some of my diabetic patients attend for colonoscopy with glucose readings in the normal range, which they tell me they never get. I always point out to them that typically patients consume less carbohydrates during the preparation than in their normal diet, and thus their blood glucose levels can be much lower. This is why we reduce the diabetic medications by 50%. I tell them, though, that this goes to show that if they want to do a lower carbohydrate solid food diet when they transition back after the colonoscopy, they could easily have much better diabetic control going forward with less medication. This is always an excellent opportunity to explain to diabetics the importance of a lower carbohydrate diet in order to reduce their dependence on their diabetic medication. Many diabetic patients on a low-carb diet can in fact reverse their diabetes, lose weight, and subsequently develop normal glucose control. Colonoscopies do have risks. There have been multiple studies looking at complications over the last 20 years. Serious harm is approximately 0.2% in one meta-analysis. A meta-analysis is a technique of putting together research results by using different statistical methods to retrieve, select, and combine results from previous separate but related studies to draw an overall conclusion. Serious harm in this meta-analysis was related to post-procedure bleeding or perforation. In the vast majority of instances, these complications were only seen when a polyp was removed. Commonly quoted risks are approximately 1 in 2,000 of perforation, 2 in 1,000 risk of postoperative bleeding, which would typically be from polypectomy, as I just mentioned. Less likely things like biopsies would cause bleeding. Death is very infrequent, 3 in 100,000. When we see a serious complication, sometimes that will require an urgent treatment or even an operation. Risks are obviously much higher in older patients who have other medical conditions such as heart failure, chronic lung disease, heart rhythm abnormalities, stroke, or cancer. Risks related to sedation are very uncommon. The bowel preparation itself can cause side effects including nausea, vomiting, bloating, and rarely fluid or electrolyte abnormalities. Sedation is given through an intravenous for the majority of patients having a colonoscopy. Approximately 10 or 20% of my patients prefer to have the test carried out with no sedative medication. They are able to talk with me throughout the procedure and watch the findings. Some patients have discomfort during the test, and so conscious sedation is given to alleviate anxiety and discomfort in the majority of other patients. Conscious sedation, which we give for colonoscopy, is not general anesthesia. General anesthesia is where a coma is induced and you're temporarily placed on life support ventilation while a surgeon is performing an operation such as an appendectomy or cholecystectomy, for example. Conscious sedation is a much lighter level of sedation to keep you comfortable and relieve any discomfort that you might have. You will breathe on your own, and if we need you to change your position during the colonoscopy, you will be able to with the assistance of the nursing staff. Often changes in position can help the scope pass through certain segments. Most conscious sedated patients have no memory of the test. Even though sometimes towards the end of the procedure they may have some vague awareness. If the procedure is prolonged, I will often ask the patient if they start to become more aware if they wish to have additional medication, and that can be prescribed if they're uncomfortable. Next is the consent. Before the procedure, I speak to my patients outlining the procedure in detail. I review the nature of the procedure, benefits, the risks, and any relevant limitations. I tell my patients, do not hesitate to ask if you have any additional questions. It's important if there's any change in your health or if there's new medications, this must be brought to my attention. If there's any chance that you might be pregnant if you're a young female, this must be brought to my attention as well. Colonoscopic positioning. This image is from the UK Cancer Research site, and it highlights the position that you will be when you're in the endoscopy suite. When you're ready, we position you onto your left-hand side and you will be facing the screen just like in the picture. If you're having this done without sedation, you will be able to watch and talk to me throughout the procedure. If you're being sedated, which is your choice, Then we give you sedative medications once you're in position. Some general points. Arrive for your procedure 1 hour beforehand. You need to bring your health card and a list of your medications. Leave your valuables at home. It takes time for you to be assessed by the nursing staff and prepare for the procedure with an intravenous and appropriate attire. It is important, if there's any residual fluid in the colon, that you go to the bathroom to evacuate this prior to the colonoscopy. Colonoscopies typically take 15 to 25 minutes if there's no significant pathology found. It can take much longer, even up to an hour, if additional procedures such as multiple or complex polypectomies are needed. While we make every effort to be on time, elective cases can take longer than expected, and sometimes emergent cases take priority. I always recommend that patients bring something to read and be prepared to wait. Patients are typically discharged 20 to 60 minutes post-procedure from the recovery area. If needed, blood work can be done post-procedure, as well as additional imaging, if needed, to further evaluate your symptoms can also be arranged at that point. I will speak to you post-procedure. If you wish me to speak to a family member as well, I'm always happy to oblige. Let the nursing staff know this. I will give you a discharge sheet which will circle the relevant colonoscopic findings and the follow-up plan. If you did not receive sedation, you can go home immediately after the procedure once you have changed, and you can drive and go about your day as you normally would. Of course, if you receive sedation, you must have a family member or friend to take you home and remain with you. If you've received sedation, you cannot drive, operate machinery, or make any major decisions the rest of the day. Most patients have no discomfort after the colonoscopy. Very few may feel some slight bloating due to residual gas. As I mentioned, I use CO2, which gets absorbed very quickly, and so any bloating should subside with the passage of gas, usually within 1 or 2 hours. Most patients can resume a normal diet immediately after the procedure. If you have any abdominal pain, bleeding, which I would define as more than 2 tablespoons, nausea, vomiting, shoulder pain, or fever, do not eat or drink and attend the emergency department. In the unlikely event that you do attend the emergency room, please let my office staff know. There are many different preparations that can be used for successful colonoscopy. The preparations that I utilize have separate videos here on my YouTube channel. The preparations are the worst part of the procedure for you. They are, though, the most important part of the procedure. Remember that an inadequate bowel preparation leads to longer procedural times, lower success rates, lower detection of abnormalities, and an increased risk of adverse events. So it's really important to make sure you do a good job with this. In my preparation videos, there are many tips of the trade. If you are having a colonoscopy done, I strongly recommend viewing these. Please click the links for specific preparations. I hope you learned a lot about colonoscopy today. Thank you for watching Medicine with Dr. Moran. I'm Dr. Keith Moran. Remember, get healthy and stay healthy.